All right, so we'll go ahead and get started. I'm going to kind of do a whirlwind tour of where we kind of sit and where we're going with nuclear cardiac techniques. And I'm going to focus on several areas, stressor agents, radiation reduction techniques, because that's always a hot topic in nuclear in terms of how we can reduce our radiation exposure, advances in gamma camera and software technology, and new applications both with PET and SPECT. So let's first start off with stressors. As you all are well aware, in the old days we had non-specific adenosine agonists, which affected many different types of receptors, including the A2A, which is important for, well, critical for vasodilation, as well as the A1, which caused, unfortunately, abnormalities in AV conduction, and the A2Bs and A3s, which resulted in bronchospasm and other untoward side effects. So the idea was to develop A2A agonists that would be more selective, or at least semi-selective, for that receptor, as compared to these other receptors, which adenosine and dipridamol are nonspecific in terms of their adenosine receptor affinities. So several years ago, the Regadenoson was developed as a agent that could be given as a 400 microgram dose, no weight dosing in any patients, just one dose fits all. And it was compared to adenosine and showed very promising results in terms of comparison using visual interpretation of images where patients either got adenosine-regadenoson studies or adenosine-adenosine studies. And then all of these studies were independently read by 3 different investigators to look for comparability. Now, as you can see, in this trial, there were 2 major advanced studies, the study 1 and study 2. Comparability in terms of agreement from adenosine to regadenoson versus adenosine were very comparable in both the first study as well as the second study. And this study actually led to approval of regadenoson as a pharmacologic stressor agent. So we also later down the line in 2015 published these data using quantitative analysis and also showed a very tight comparison in terms of total defect size by regadenoson on the top and ischemic defect size, adenosine versus regadenoson, using quantitative analysis. And so you can see that the red line pretty much goes through 0 as the line of identity. So a very close comparison in terms of defect sizes. And in fact, when you look at Bland-Altman analysis, also very tight boundaries in terms of what was shown to be one perfusion defect size by regadenoson versus what you saw in the same patient with adenosine. And in fact, if you look at reproducibility, yes?
Quick question.
Yeah.
The outliers.
Yeah.
What are more likely? What are they more likely? Have anybody? You went in and look at those outliers just to learn?
I think most of the outliers. Yeah. No. Well, I mean, first of all, the higher the defect size, the larger the defect size, the greater the variability. That's number one. Okay. Without it, I mean, if you have a 5% defect, it's unlikely to be a 20% defect. So the variability does go up somewhat with the size of the perfusion abnormality that you see. Okay. But I think it also has to do with image quality, Mike. You know, so in patients that have one study which is superior in image quality compared to another, you're more likely to see variability.
It's almost like a reproducibility of a study.
Yeah, yeah. Well, actually, that's what I was going to show you.
That almost represents a study on reproducibility rather than a study on.
Well, if you look, that's why I have this up here too. If you look at adenosine comparisons, 92% of patients had less than a 5% absolute change in defect size, but that was the same thing for adenosine regadenoson. So it's like a normal Gaussian distribution. I mean, you have a bell-shaped curve and you have extremes on both ends. Yeah, exactly. So anyway, I mean, the fact that you see the same kind of bell-shaped reproducibility with adenosine when you compare it to regadenoson versus adenosine on itself indicates that, you know, this is very tight comparison. And this is just an example of a patient with a big anterior defect. As you can see, that's the one on adenosine. This is the regadenoson one in the middle, and the rest study showed ischemia. And quantitatively, you can see virtually an identical perfusion defect. Green is ischemic, black is scar. So even the scar or ischemic patterns were the same. So as you know, here we use quantitative analysis and have done so for many, many years. And it really helps us tremendously in terms of being able to determine whether a real change has occurred versus variability. And that data has been published. Data was published many, many years ago. The other issue behind regadenoson is its safety issues. And as you know, with adenosine, you really can't use the agent in patients with COPD or asthma that have advanced disease because of the issue of developing changes in FEV1 and having bronchospasm, et cetera. So there have been many different studies looking at the safety of regadenoson in this kind of populations with COPD and asthma. And in fact, the largest study, which was 999 subjects. Why they couldn't enroll just one more person, I don't know. I like round numbers myself. But 999, it was a randomized, double-blind, placebo-controlled trial between patients who had regadenoson versus getting just saline infusions. And if you look at the data, and the main outcome was to look at change in FEV1, which is a more categorical way of looking at changes in pulmonary function, you can see that if you look at a greater than 15% reduction in FEV1 with regadenoson versus placebo versus saline, actually regadenoson did better than placebo. Not statistically, but certainly there was no difference between regadenoson and placebo. And you have to also remember that this population was a wide variety of patients. They were all clinically stable, but a lot of them had advanced COPD, and many of them had at least mild to moderate asthma. And what was also found was that the percent of subjects who had more than a 15% reduction in FEV1 was not influenced at all by baseline disease. Okay, so irrespective of disease severity, patients did well when they received regadenoson as compared to placebo. So because of this, now we routinely use regadenoson in our patients who have COPD, whereas in the old days we would never have used adenosine in that population. This is another study looking at regadenoson in heart failure in heart transplant patients, and that's important because typically we do not use adenosine. Well, we don't use adenosine in patients with heart transplantation because of the high incidence of AV block. And what you can see here in terms of conduction abnormalities specifically in this study, which compared adenosine to regadenoson, is that second-degree AV block occurred in about 13–14% of patients with adenosine, but virtually no patients with regadenoson. In fact, there was no third-degree block, and sinus pauses were also less with regadenoson versus adenosine. So in patients who get transplantation, there's fairly good data now to show that those kind of patients can receive regadenoson as a stressor, whereas adenosine would have been contraindicated. So in terms of looking at different vasodilator stressors and different agents, we basically have eliminated dobutamine as a stressor agent in nuclear cardiology, which we're very happy with because I used to get more arrhythmias with giving dobutamine than my patients did. And so we got rid of that. And as far as adenosine and dipritamol, we really don't use them at all anymore. The only indication really for using adenosine or dipritamol in this day and age is if you have someone after early myocardial infarction, because there's really no data with regadenoson in that population. But there is safety data with adenosine in patients early post-MI. So that would be a population that you would use those other pharmacologic vasodilators in. But as far as dobutamine, we hardly ever, never, ever use it anymore in stress testing in patients who can't exercise. The other thing that's interesting is this particular trial. This was the EXERRT trial, and it compared early administration of regadenoson on the treadmill within 3 minutes of stopping maximal exercise versus waiting an hour. Because there are a lot of patients who you want to try to do exercise in where you're afraid to do it because you figure they can't get on the treadmill. They're not going to get up to 85%. Let's just do a pharmacologic stress test. But I think everyone who can possibly exercise deserves a chance to do a maximal stress test. So that's what this study basically did. It took over 1,000 patients and of those who were going for treadmill testing and randomized them either to a early regadenoson administration while the patient was on the treadmill after it had been slowed down to just 1.6 miles per hour and after 3 minutes on the treadmill walking at no elevation at that speed versus waiting an hour to give regadenoson. And so you see in this study there was an initial rest MPI, and then there was a stress MPI, so it was a rest-stress protocol, and that was 96% of patients who had that. And then they got randomized, and then you'll also notice that there was a second MPI study, just a stress-only study, done several weeks later. Okay, and the reason for that was to compare the initial versus the second study. Okay? If you look at all of the hemodynamic changes and looking at the safety data, there was really no difference in terms of developing hypertension or hypotension or fast heart rates, irrespective of whether patients were on the treadmill or whether they waited an hour and then had another study, or on the second study where everyone just had rest regadenoson. So you can see on the top, you can see the heart rate responses, you can see on the bottom the blood pressure responses. If you look at other kinds of secondary endpoints in this trial, there was no significant difference in side effects whether patients were on the treadmill or off the treadmill. That's a little bit strange because, as you know, a lot of the times when we give drugs like regadenoson or adenosine, we actually put patients on the treadmill to try to avoid side effects. In this particular study, there was a trend, but it didn't really show much of a difference in terms of the typical side effects you get. There were 2 people who did develop an acute coronary syndrome who were randomized to exercise followed by early regadenoson administration. What's important to realize about those 2 patients is that they both had evidence of ischemia on the treadmill, okay, and into recovery, okay? And that's important because we know that there is absolutely no value to giving a pharmacologic agent in someone who's already been exercised and demonstrates myocardial ischemia. You've already proven your point. If someone develops chest pain and SC segment depression on a treadmill, you inject them with the radiotracer. You don't slow down the treadmill and then give the patient regadenoson. That makes no sense at all, okay? So moral to that story is you should at least wait a couple of minutes, as they did in this study, to make sure patients don't have SC segment depression with exercise or into recovery. And that's important because if you look at these data from many, many years ago, back in 1998, somewhere around 20% of patients never develop ST segment depression on the treadmill during exercise. They just get it in the recovery phase, okay? And if you look at ST segment depression in the recovery phase, is just as bad as having exercise induced, okay, on the treadmill, maximal exercise-induced SC segment depression in terms of outcomes. So it is important when we stress our patients, and we're going to do an early regadenoson administration, that we wait a couple of minutes to make sure they don't have, first of all, exercise-induced SC segment depression, which would be a contraindication to giving regadenoson, or SC segment depression into the recovery period. But by using those parameters, you get actually very nice results. The other thing I want to show you, which is also very intriguing, because this has never been shown in a clinical trial before, and it was kind of a secondary finding, but this is looking at the exercise, initial exercise, followed by regadenoson data. This is study 1, study 2, and the second regadenoson data. And what you'll notice here is that if you look at the agreement rates, they are very, very high. 73 and 75%. Okay, so that's comparing the exercise and then early recovery doing the injection versus the second study, okay, or just the regadenoson 1 hour after exercise versus the second MPI. But what is interesting about this data, which I think is much more exciting, is this issue that if you look at the initial exercise regadenoson data and look at the people who had only had 0 to 1 abnormalities, like a normal study, on the second study, somewhere around 10% of patients went on to develop ischemia on the second study, which was stress only, okay? And that was true irrespective of whether you look at the exercise regadenoson randomization or the regadenoson randomization. So what is the issue here? The issue is here that more than likely when you do a rest stress study, because of shine through from the rest dose, you may not pick up ischemia on the stress dose. Okay, you may mask ischemia because you haven't allowed the rest radiotracer to decay to a large enough degree. So you may mask ischemia, whereas if you do stress first, you have no contamination from any kind of rest study. And that's why for years we have been promoting this whole idea of doing stress first imaging rather than rest stress imaging. Not necessarily because of this concept, but this is a very interesting concept to show that maybe that is the way we should do it. Maybe all patients should get stress first if you really want to maximize your ability to identify ischemia. Now, the investigators in this study actually recommended, well, you know, because there may be shine through from the rest study, maybe we should even give higher doses of radio tracer on the stress study. My contention to this would be that's completely self-defeating. Why would you even give more radioactivity? The idea here would be, why don't you just do stress first, give the least amount of radio tracer possible, and get the optimal results. So with that in mind, number two, in terms of what we're looking at today, new acquisition or better acquisition protocols. You know, for years we've pushed forth the concept of stress first imaging to achieve stress only if the study is normal. And there was a lot of pushback on this because people thought without two sets of data you could not make a rational decision in terms of whether a study was normal or abnormal, and you might have a worse outcome in patients who had stress only imaging. Well, Dr. Chang put forth a study in 16,000 patients from here, showing no difference between stress rest and stress only in patients who had normal studies. And Milena Henslova, Duval et al. Also published similar data, very close, timely to our own data in JACC. And you can see on this slide that if you look at stress only versus additional rest imaging, there's no difference in outcome in terms of total survival. And the nice thing about it is that you markedly reduce the amount of radiotracer you give, 21 millicuries versus 55. And of course, you maximally reduce the radiation exposure. In fact, 60% of our patients with stress only receive less than 5 millisieverts of radiation. So not only is it safe, but it's beneficial to the patients because they get much less radiation. And remember that in today's environment, somewhere around 70% of patients will have normal myocardial perfusion scans. It used to be just the opposite. It used to be like 30%, like a decade ago. But Rosansky published data very nicely a couple of years ago and showing the trends in nuclear cardiac imaging. And you can see that in nuclear cardiology, more and more patients being imaged were normal patients as compared to a decade ago. So it makes sense, with that in mind, to do a stress-first approach. It also makes sense from a technologist point of view. I see we have some of our technologists back there. And this is, again, nice data from Milena Henslova looking at total radiation dose in terms of deep dose equivalence, shallow dose equivalence, and lens to the eye equivalence. And what you see across here, if you look at patients, if you look at a period of time, a 12-month period where patients were just imaged without stress first and without new gamma camera technology versus a year later, 50% reduction in radiation exposure to staff, not only just to patients, but to staff with the use of these kind of techniques. And although CZT technology, cadmium zinc telluride gamma cameras, do reduce radiation exposure, you can see from this particular graph that most of the radiation exposure reduction is actually done by giving just a stress dose, and if that's normal, having no additional radiation exposure to the patient or to the staff. So using advanced technology, using stress-first imaging, you not only markedly reduce radiation exposure to the patient safely, but you also markedly reduce radiation exposure to your technologists and your nursing staff who are taking care of these patients. Okay. This is the study that we actually published last year. Yeah.
What's the uptake in the nation of stress only?
What's the what?
What's the uptake in the nation of stress only?
Oh, well, I'll get to that in a minute. But it's abysmal. And it's maybe at most 2 to 3% of patients. If you look at the IAEA data, which I'll show you in a second, I mean, I can tell you here, we kind of promoted this and have pushed it over the years, but it's done very infrequently in North America particularly. If you look around the world, it's even done even more so in Africa and Asia than it is in the United States, which is pretty sad, honestly. This was a study, you know, there's been a lot of talk about what's the best way to evaluate patients in the ED. So this is a study that actually we published last year looking at MPI versus CT in terms of radiation exposure, getting people out of the hospital, et cetera. It was published in the Journal of Nuclear Medicine, and it looked at 600 consecutive patients randomized either to CT or to stress myocardial perfusion imaging. And you can see baseline characteristics in these patients were similar. Their mean age was 53, 56% were women. BMI was 32, kind of a typical risk factor profile, diabetes, hypertension, smoking. Their TIMI risk score was low, and in fact, most had a TIMI risk score of less than 2 as by protocol. And again, if you look at the MPI protocols, about 25% of these patients had stress-only imaging. The rest had some form of rest or stress imaging. The CT protocols, 20% were prospective imaging. The rest were using dose modulation with retrospective imaging. And as you can see here, as you would expect, 96% of patients had normal MPI studies. 87% of patients had normal CTA studies. So you have to even wonder why you image these patients. And that's a whole nother topic of discussion. But be as it may, due to medical legal issues mainly, patients are still imaged in the ED who have these low-risk characteristics. What I want you to show you here is if you look at CT versus SPECT, and the blue looks at the time from admission to randomization. The green is the time from randomization to imaging, and then the yellow is the time it took from the completion of imaging to interpretation of the images, and then from interpretation of images to hospital discharge in red. And what you can see is that CT was superior to all of SPECT in terms of time to diagnosis, in terms of time to hospital discharge. But if you look at people who had normal CTAs and normal stress-only images, you can see that the results were virtually identical. And again, it's the speed of not having to do that extra rest image that allows patients to have quick acquisitions, quick image interpretation, and out the door, okay? And this is even more distinctly expressed when you look at normal stress only versus stress standard at the bottom, where doing a stress rest or a rest stress imaging protocol added almost 3.5 hours of time to the acquisition protocol and therefore to hospital discharge, et cetera. So again, a very important issue of using stress first as the way to do things in terms of time to diagnosis, time to discharge. Radiation exposure actually was less with MPI in this study, 5.7 millisieverts versus 12.4 with CT. Now, that was using our 64-slice scanner. With our new scanner, we'd probably be about the same in terms of 4 to 5 millisieverts of radiation. But this is using a 64-slice scanner, which I can tell you is still the standard in the general community. And hospital costs were no different with nuclear versus CT. So doing a stress rest protocol, again, is very beneficial in terms of evaluating patients in multiple settings, including in the ED, where you want to get people in and out, particularly since recognizing that over 90% of those patients will have a normal stress study and will be done. End of story, out the door. Now, these are the ASNC guidelines that are just coming out this year in 2018. And I was I was on the writing committee for these guidelines this year. And this is the first year that we have an entire section just on how to do and why we should do stress-first imaging. And ASNC has absolutely endorsed this whole concept of getting away from rest-stress and doing nothing but stress first as the way to assess patients. And in fact, there have been many different editorials on this as well. This is one initially I wrote back in 2010. This is another one that was written by Gary Heller. Mine was stress-only imaging. Is it time for a change? Heller wrote stress-only imaging. It is time for a change. Henslova wrote stress-only imaging faster, cheaper, less radiation. So what's the holdup? And this is something I wrote just this past year. Implementation of stress-only. What will it take? And I guess it's a really intriguing question because, especially in light of this study, this was the International Atomic Energy Agency study that I was involved in with Andrew Einstein and many others, where we actually looked at what kind of imaging was performed in labs across the world. So we collected data on 8,000 patients undergoing MPI in 308 laboratories across 65 countries. And the primary objective was to look at how many labs use radiation optimizing best practices to achieve their imaging. And you can see these are the different laboratories from Africa, Asia, Latin America, North America, etc. 55 labs from North America. What is interesting from these data, and this is looking at the number of people who had stress-first imaging. Overall, about 51% of patients across the world had stress first, and about 11 to 12% had stress only. But in North America, only 7% of patients had stress first, and not surprisingly, only 3% had stress only. So in a country, in a continent, where we supposedly are doing the most sophisticated work, okay, we're nowhere in terms of what we should be doing, okay? And in fact, that has big consequences because if you look at non-stress only versus stress only, you have anywhere from 12 millisieverts down to 5 millisieverts of radiation exposure, which is over a 50% reduction in radiation exposure if you use stress only imaging. And yet in our country and in our continent, we don't do that. Except maybe here at Methodist Hospital, okay? And in fact, if you look at radiation exposure across the different continents, you can see in North America, only 30% of patients actually received less than 9 millisieverts of radiation with their studies, which is what ASNC has put forth many years ago. This is like 5 or 6 years ago, saying that should be our gold standard. Nowadays, we have much lower standards. We're trying to get down to less than 5 millisieverts of radiation. But it's abysmal how we're doing, okay? And so there are many reasons why this is so. A lot of it has to do with inexperience, frustration with reading stress-only images and not being confident that the study is really normal because of artifacts, etc. There's also issues of reimbursement. In this Medicare, well, actually, if you do in some states, not here, but in Texas, but in some states, if you order a stress myocardial perfusion scan and you do stress first and don't do any rest imaging, they won't pay for it. The other thing is that you actually get paid for doing both a stress study and a rest study, both from a technical component as well as from as far as professional fees. So if you really want to maximize your money or maximize how much you're getting reimbursed, of course you're going to do stress. You're going to do stress and rest instead of just doing stress only, right?
Dr. Marian?
Yeah.
Just to go back to CT for a second, you showed that you're more likely to diagnose coronary disease.
More likely to what?
So you showed that you're more likely to diagnose coronary disease when you do a CT, and that it's now lower radiation, just like also the PROMISE trial and the British trial. But why is it that the outcomes were essentially the same?
Well, that's a very interesting finding. I mean, I'm not here to really talk about PROMISE, but PROMISE obviously was randomized between functional testing, which was mostly nuclear imaging, versus CT. And what's interesting in that trial is that even though there were twice as many patients getting CAF'd and twice as many revascularization procedures performed in the CT group, the outcomes were no different. You're absolutely right. Now, one has to wonder why that is. Maybe those patients didn't really need to be, if someone has a 50% lesion and it's not functionally significant, what advantage do you have from revascularizing a patient like that? Okay? So there are a lot of issues. Now, there's actually some data that Pam Douglas has put together looking at the issue of using FFR with CT. And actually, HeartFlow has put together some data. They're the ones who do all this, which have actually shown that by using FFR, you might actually be able to tailor better who would benefit from revascularization. But again, that's an ad hoc, now post-trial analysis.
What I was thinking is, aren't they more likely to end up being on aspirin and statin, essentially compared to the more nuclear patients?
Possibly, okay? I mean, there are data to support that. There's no data specifically from PROMISE, but there is data to support that in other trials.
I mean, the major driver for rest as well as stress in the United States is reimbursement.
Yeah.
There's no question about it. And that's why you see in Africa.
Well, I wanted to be subtle, Bill. I didn't
No,
know.
there's no subtlety. There's no subtlety. And I think here we're talking about safety
Right.
of radiation.
That's exactly
in addition
right.
to cost and safety of radiation for the people in the lab.
Yeah.
So I would like to see from ASNC and societies and ACC a push actually for reimbursement to entice people, meaning if you have a normal rest and a normal stress that you know you may not get reimbursed.
That's exactly right.
And you need to push it, and the only way to push it in this country is by reimbursement.
That's right. That's exactly right. Okay, let me move on. I just want to say that there are some ways that we can kind of approach this, because there are, as you all know, we do get attenuation artifacts. Now, in our laboratory, we read around attenuation a lot. A lot of physicians don't feel comfortable with that, but there are ways to get around it. There are CT and line source ways of doing attenuation correction. And we know, this is a study that was done in patients who had bariatric surgery, where attenuation correction was done, stress only was done in the majority of these patients, because they had attenuation correction algorithms to help guide them that they didn't need a rest study, okay? So there are ways to do that, and we know from many other data, these are data from Thompson, showing that if you look at all patients and look at patients with very high BMIs, that attenuation correction clearly improves your ability to say a study is normal, okay? So these are ways you can do it. But there are other things you can do. If you don't have attenuation correction in your laboratory, what else can you do? You can do this. You can do prone imaging. Now this is something that we're really pushing again. It's something that where there are a few studies out there, but not a lot of data. But these are just some examples from our own laboratory. This is a patient who had a supine stress study and a prone stress study. And you'll notice that there's an anterior defect on the supine, but on the prone, it goes completely away. Okay? And again, you'll notice there's a little apical defect on the supine, and on the prone, it goes completely away. Okay? If you look at the polar maps, you can see that on the supine image, you have an anterolateral defect. On the prone images, you have no defect from a quantitative point of view. And if you look at the raw data, you can see that this patient had significant breast attenuation. So you can see this breast shadow right here, okay? And the wall motion was completely normal. So this is a patient in our laboratory that we would call normal, okay? Even though we didn't have advanced attenuation correction and all of these things, by simply taking the patient and changing them from supine imaging to on their belly doing prone imaging, you change the attenuation characteristics. Either they go away or they're altered. And true defects don't change their location in the heart, okay? So if you see a changing defect on someone with a normal, otherwise normal study, that's artifact. Here's another example of someone with an inferior defect. I think you can appreciate that. Okay? You know, in the old days, before prone imaging, I probably would have called this normal anyway, because I would have looked at the raw data. But on the prone images, notice the defect is totally gone. Again, this is a shift in attenuation artifacts that can help you and can guide you into what's a normal study and what's an abnormal study. And again, if you look at the raw data in this patient, you can see this patient actually had significant diaphragmatic attenuation, which was the reason for this. and the wall motion was entirely normal, which of course is very important because if the wall motion were abnormal, we couldn't call it stress only. We'd have to do rest imaging. Okay? So there are ways in which people can use other techniques besides advanced technology to get around this issue of attenuation artifacts if you're unsure if a study is normal or abnormal. Okay, so that's clear. Let's talk about some other things. Let's talk about improvement in software algorithms. You know, up until recently, we always used filtered back projection. Now we use iterative reconstruction. Iterative reconstruction is a best guess way of deciding. It's an algorithm where the computer basically looks at a set of data points and then it guesses and then takes that guess and improves upon it in terms of getting better image quality. Iterative reconstruction, you can reduce your radiation exposure by 1/3. You can give 1/3 the radiopharmaceutical and still get the same type of images. Okay, so that is good for radiation reduction. You also get, with iterative reconstruction, you get noise reduction. Noise is one of our enemies. Noise is caused by low counts. By using iterative reconstruction and noise reduction modalities, you can improve, again, image quality. And most importantly, there's this thing called depth-dependent resolution recovery. Now, I talked about this a couple of months ago when I was talking about the basics of nuclear cardiology. But the bottom line is when you have a patient and you have a collimator, here's a source. This is a point source and a point source. Here's the point source out here, right? If you have a collimator, the further that point source goes away from the collimator, from the camera head, the worse the spatial resolution. So here you'll notice that here you have this point source. Look how blurred and large this is compared to when it's here, how it really reflects more actuality, okay? So we always tell our techs to put the camera as close as possible to the chest wall, not to increase counts. Doesn't do anything for counts, but it increases spatial resolution. But the problem is that the heart is a three-dimensional structure, and the basal inferior portions of the heart are the deepest. So it's no surprise that the lateral wall not only has the most counts because you don't get a lot of Compton scattering, but you also have the best resolution in the lateral wall because it's closer to the camera head. The posterior and inferior walls of the heart and the septum are the worst to look at because you have most scatter, because they're deep structures, and you get the worst resolution. So there are ways now that we can do depth-dependent resolution recovery using iterative reconstruction techniques to compensate for the loss of spatial resolution that we see in the heart, which you cannot do any other way because, unfortunately, the heart does sit in the chest, and it is deep within the chest, and some areas are deeper than others. But these are ways we can get around it. Using those kind of techniques, it's been very nicely shown using all different types of software and comparing it to routine imaging, that iterative reconstruction with half the dose or half the time does just as well as full-time routine SPECT imaging. And in fact, here's some examples of full-time half dose or half-time full dose in the same patient. And you can see that the image quality is virtually identical with the same type of perfusion abnormality. So using these kind of software algorithms, we're able to compensate again for some of the resolution loss that we see because of depth of the heart in the chest, and also reduce radiation exposure and improve relative count density because of using iterative techniques to improve upon that. Also, there are gamma camera differences that we can now use, right? You have to remember that photomultiplier tubes, which are the standard in nuclear cardiology, are really somewhat of an archaic way to assess perfusion and to assess count rates. And with collimation, 99.9% of photons coming out of the body are never hit the camera. So only 0.1% of all radioactivity administered in terms of photons emitted from the patient actually make up the image. That's kind of sobering, but it's true. Now we have new ways of doing this with CZT, cadmium zinc telluride cameras, and there are many different vendors. We have a GE Discovery pinhole system. There's also the DigiRad system, the Spectrum Dynamics system. And these systems have much better spatial resolution, much better energy discrimination, And since they acquire counts at a higher rate, you get much better count density for image interpretation. And if you compare different studies that have been performed over the years, all of these different systems perform excellent compared to other systems, just routine gamma cameras, in terms of image quality and detection of perfusion abnormalities. This is just one example of a study from Duval, where they did several different acquisitions with a CZT camera or a regular camera looking at image quality. And this is a 5-minute rest versus a 6-minute rest, and then a 3-minute stress versus a 5-minute stress, and then compared to a routine stress image that was 15 minutes here. And you can see the image quality is not degraded despite the fact that you have less time imaging, and you can get these things done rather quickly. And of course, from radiation exposure points of view, with CZT, using a low-dose protocol of 5 millicuries, we can get a radiation exposure of just between 1 and 2 millisieverts. So rather impressive, okay, in terms of how we can achieve things. And that's important because on the flip side, in my own lab, CT can already achieve that in certain selected patients already. So it's kind of good. We're kind of bouncing one technique against the other. Another area where we're really developing, and I'm going to try to go through some of this quickly, is in this whole area of using perfusion derived PET imaging, looking at vascular reserve. And coronary flow reserve becomes worse as you go from microvascular disease to diffuse CAD to clearly obstructive disease. But what's interesting is that when you look at coronary artery extent, if you look at the x-axis, coronary disease extent, and look at coronary flow reserve abnormalities, it's very heterogeneous. So just because you have extensive coronary disease doesn't necessarily mean you're going to have abnormal coronary flow reserve. And just because you have non-obstructive disease doesn't mean that your coronary flow reserve is going to be normal, okay? So since these are somewhat disparate, you can imagine how you might use these complementary to look at overall risk. And in fact, that's been done. If you look at these particular data, these are patients with high or normal coronary flow reserve and low CAD extent. They have the best outcome. Look at this group down here who have low coronary flow reserve, irrespective of CAD extent. They do poorly. They do poorly. So coronary flow reserve or lack of coronary flow reserve is a very important prognostic indicator, and at this juncture is really the basis for doing PET imaging, because PET is the prototype for doing this kind of analysis. It also may guide therapeutics. If you look at patients who have high coronary flow reserve, it doesn't seem to matter whether they get revascularized or not. But on the right-hand side, if you look at people with low coronary flow reserve who don't get revascularized and have extensive disease, they do very badly as compared to those who get bypassed who have the best outcome. So coronary flow reserve, irrespective of disease extent, might actually be a nice way of assessing the true risk of a patient and who might benefit from certain procedures. It's also true that coronary flow reserve abnormalities tend to be more common in women and tend to be more common in women with non-obstructive disease, whereas men, generally speaking, don't have a lot of coronary flow reserve abnormalities if they have non-obstructive disease. They get more coronary flow reserve abnormalities as disease extent gets worse, okay? But one thing we know, that if you look at overall risk for any amount of abnormality in coronary flow reserve, women do worse prognostically, okay? So there's something about the microvasculature, and it isn't really clear yet in terms of what it is. But clearly those patients do worse clinically than they do with epicardial disease necessarily with abnormal flow reserve. And so even though women have less obstructive disease, they clearly have more microvascular endothelial dysfunction, and they have a worse outcome if they have those kind of findings. Now, with that in mind, as an indicator of gee whiz, maybe this is important stuff, what can we do from a SPECT point of view? Well, there's actually several studies now looking at actually quantifying myocardial blood flow with SPECT imaging, not PET, but SPECT. And in fact, we're getting one of these cameras in our labs now. This is with the Siemens. This is the new Siemens system where this study was done, looking at coronary artery disease in a small number of patients and doing flow studies. These are dynamic flow studies down here where you actually track the bolus. So you track the bolus going through the lungs, going through the right ventricle, into the lungs, into the left ventricle, and you can see the final images down here. Well, if you look on this side, it's probably better to see. This is the bolus tracking, and then this is the final image here where you can actually see the myocardium, right? And you can see the bolus initial tracking and the uptake, okay? If you look at this particular study, if you look at people who had really no significant coronary disease, coronary flow, absolute coronary flow during stress was much higher in those than those who had coronary disease. And that was true whether they had LAD, circumflex, or right coronary artery disease, okay? So one of the first studies to show that you can actually accurately assess myocardial blood flow in patients and be able to determine that those with non-obstructive disease actually have better blood flow than those with obstructive disease. And of course, that also comes down to myocardial flow reserve, where you can actually look at the flow reserve here and see that it's normal in patients with non-obstructive disease and it's abnormal in patients with obstructive disease. So, first study of its kind really to look at this issue of using SPECT imaging with a very high quality, high count resolution imaging system to look at absolute blood flow using the same kind of modeling that's used in PET imaging. And this is just an example. This is a patient from this study who had a completely normal myocardial perfusion scan. You can see the images here. I don't think any of us would think that was abnormal. When you look at the absolute myocardial blood flow, it was markedly reduced, as was the myocardial flow reserve, markedly reduced at 1, okay? So this patient actually ended up having severe triple vessel disease and balanced ischemia, as we often say, right? Seen in about 1 to 2% of patients. I don't have time to go through it, but I can tell you I had a patient like that just this past month who had a normal perfusion scan and ended up having severe left main and a severe... But you know what, Dr. Zogby, in all honesty, okay, so I had a patient who had a clear cut, who had symptoms really suggestive of coronary disease. I did a nuke. I said, look, even though the nuke is normal, I don't believe it. Yeah, so there you go. But I mean, but this may be a way to help.
Glad you're being recorded.
Yeah, that's right, exactly, that's right. But this is a way at least we might be able to get around the problem. And I don't have to, the ROC curves actually show benefit there. This is another study using actually the CZT camera, the DSPECT camera, which showed very similar images in terms of, this is comparing CZT versus ammonia, okay? And in this study, again, if you look at correlations, very high in terms of when there was high myocardial flow reserve by PET, it was also seen with CZT, low by PET, also low by CZT. The numbers are a little bit different, and that's because of the rollover in the extraction of technetium as compared to ammonia. But still very promising initial data in terms of maybe being able to use either very avant-garde SPECT systems or CZT systems to be able to identify abnormalities in flow, not just relative perfusion abnormalities. I have 5 minutes left. I'm getting kind of hoarse myself, but I'll try to go through some of this. The other thing I want to just mention is that there are other tracers coming down the line. This is fluoroperidase. And it's an F-18 perfusion agent. As you know, F-18 has a 2-hour half-life, so you can actually do exercise with F-18 agents as compared to, rubidium, which has like a 1-second half-life, 1-minute half-life, I should say. And you can't really do that. So first I'd like to just say, what are the advantages of potentially having an F-18 agent? First of all, as I already said, rubidium has a half-life of only like 70 seconds. So it's very hard to do exercise. You can't do it. With fluoroperidase, since it has a 2-hour half-life, you could actually inject the radio tracer during exercise and then image the patient. Secondly, most importantly, we talk about rubidium, and rubidium is still the standard now because not a lot of centers have PET imaging agents like cyclotrons to get an N13 ammonia. But rubidium has very high energy. It's a very high emitter, and therefore it has a very long positron range before it annihilates into 511 keV photons, okay? So what does that mean? If you have an event occur here and it travels all the way out to here before it annihilates, your spatial resolution is markedly reduced because the event occurred here, not here, and you're recording it here. F18 has a very low energy. It's the lowest of all the PET tracers. So if an event occurs here, it travels very far and very little in tissue before it annihilates. So the spatial resolution is much better with F18. And this is reflected here. If you look at a point source, look at a point source image with rubidium versus a point source imaged with F18. You can see how much tighter that concentration is right there, right? The full width half maximum of that is going to be much tighter than it is with rubidium. So this is one of the reasons why I like the idea of potentially getting this agent. And another reason is its extraction fraction is very high. I already talked to you just in the last study about how technetium has very low extraction fractions at high flows. This agent has a linear extraction fraction, almost identical to O15 water, which is amazing. It's almost linear to blood flow, which means that you're going to get much better identification of ischemia, okay? And you're able to do exercise because it's a long-acting imaging. So this is just an example of extraction fraction. O15 water is linear to all blood flows. So if you have, for instance, during stress, a blood flow of 2.4, but in the patient, in the normal area, but in the abnormal area, it's 1.8, you can detect that 25% reduction in flow using O15 water. If you use fluoropyridaz, okay, that 2.4 in the normal region would now be like 1.6 in the abnormal region, so you could still detect a 20% difference, which is pretty good. That's almost the same as F18. Look at where we sit with rubidium. With rubidium and technetium, okay, that 2.4 would now be, because that curve is so much different. Look at the myocardial tracer uptake. Now you have very little difference. You can't detect that abnormality. So now you can only detect a 10% difference. So you go from a 25%, which is optimal, down to only a 10% because of issues of extraction at high flows. Okay? Because remember, at high flows, you want to maximize your count density in normal areas. The minimum areas are always going to be the same because they're low flow. But you want to maximize that disparity from high flow to low flow. Fluoropyridaz can do that. The primary studies looking at fluoropyridaz have shown actually improvement in specificity with that agent, sensitivity, I should say, in terms of detection of disease in patients who underwent coronary angiography in this study, with non-inferiority to specificity. And these are just some examples of a technetium study and a fluoropyridaz study, which was definitely abnormal. This agent is now in its second phase 3 study. We are going to be a site here starting in July involved in this particular trial, and I'm very excited about this because I think these agents potentially, because they've already actually, Jamshid Madahi has already done actually flow studies with this agent in terms of looking at absolute blood flow. So this may be, in the future, this may actually be the way to go. If this pans out as we hope it will, this might be the ideal tracer of the future in terms of looking at perfusion and absolute blood flow. So we're just going to have to wait and see what happens. Now, I had a lot more to talk about, but we really ran out of time. So you just can't get it all in once. Anyway. But I hope that gives you some idea about some of the new advances and where we're going and what some of the limitations have been in the past and how we're hopefully overcoming them. Thank you. Are there any? Yes, Mike.
Yeah, I really like that fine drone because it doesn't cost any money.
Yeah, it's
So do you have now a protocol that the technicians themselves make the decision to put the patient from supine to propine?
that is correct.
Yeah, so you don't have to think about it. They have their protocol. If they see something that they're concerned, they'll switch the patient over.
Exactly.
Okay.
And I tell you, it's been, you know, I don't know that it's changed what I would necessarily do clinically, because in the past, if I saw a mild reduction inferiorly and I saw a diaphragmatic attenuation, I probably would have called it normal anyway. But this gives just an added amount of security to say that what you're seeing is really normal. And for someone who's less experienced in terms of reading, it's a godsend, right? Because a true perfusion defect should not change with position. Okay, very good.